CBC is one of the most important and the earliest investigations which is done for acute leukemia. In fact, it's the first window to the diagnosis because primarily the CBC gives you whether the counts are low or high. It also tries and gives you the information from the instrument itself that perhaps you might be dealing with blasts or some abnormal cells, and that can also be picked up by the analyzer and eventually on a peripheral blood film. What's also important to realize is that acute leukemias in general can have a variable, in terms of CBC, in terms of numbers, there will be a lot of variability. For example, you can have on one side WBC counts which will be low. On the other hand, there can be markedly increased WBC counts as well, which is otherwise called hyperleukocytosis. The second point is that generally in acute leukemias, you will also have low platelet counts. And also the patients will usually present to you with anemia. So when you look at a CBC in a wholesome way, you will be able to figure out that this patient perhaps might be suffering from an acute leukemia. And then it would also need, kind of confirmation, not only by looking at the peripheral blood film, but also by looking at, eventual bone marrow examination and rest of tests. But yes, CBC still happens to be the first window through which you will be actually kind of looking at the WBC counts, the platelets, as well as the the hemoglobin levels to determine whether somebody has acute leukemia or not. Once we, suspect an acute leukemia, either clinically as well as on, CBC parameters and say on a peripheral blood film, the next important step that is required is to categorize the acute leukemia, whether you're dealing with an acute myeloid leukemia or acute lymphoid leukemia. And for that, phenotyping by flow cytometry happens to be the next most important step. And that's adopted worldwide. Interestingly, today, if we are at the anvil of the WHO Blue Book 2022 version, where most of the leukemias now have a genotypic signature or a molecular signature, and that also not only determines whether the prognosis will be different, it will also determine the therapeutic interventions. So, for example, if a patient has acute promyelocytic leukemia, the defining abnormality of translocation 1517 can be picked up by molecular means also, as well as cytogenetics. And on molecular assays, you will also pick up what is called the PML-RARA mutation. So therefore, an intricate network of CBC, peripheral blood film, flow cytometric immunophenotyping, cytogenetic studies, and eventually molecular typing. And in today's era, the next generation sequencing actually gives you the entire information about tackling an acute leukemia. And that also not only determines, as I said, therapeutics, it also determines eventual interventions. So this whole thing has to be done in unison to come to a correct diagnosis in a patient and subsequent treatment. A complete blood count on a hematology analyzer, in fact, as I said, is the first window of opportunity to pick up the the nuances of a cancer or an acute leukemia in an individual. There are certain parameters which come up from the hematology analyzer itself. For example, if you look at the data which is coming from the three-dimensional data of the white blood cells, that itself gives you an idea whether you're dealing with an acute leukemia. The scatter plots which are there from a hematology analyzer also determines whether there is presence of blasts or not. There's something called immature granulocyte percentage which people look at, and if you have a significant leftward shift with presence of blast, which the analyzer will highlight, again will make you suspect that there is an acute leukemia. And to add to it, if you have evidences coming from low platelet count and low hemoglobin, that gives you further kind of confidence that perhaps you're dealing with an acute leuke. In addition to all this, you would also like to go back and look at the research parametric data, which is today available in most of the hematology analyzers in the research mode. And from there, you're able to get some more information which gives you insights whether you're dealing with an acute leukemia. And at times, it can also give you information to differentiate subgroups of acute leukemias to a large extent. When I say this, it doesn't mean that we will not do subsequent investigations, but for the basic part of it, and at least screening and picking up the acute leukemia, you are able to do this by using an analyzer. So the biggest challenge that you have in a hematology analyzer, in terms of identification of abnormal cells or blasts, is that the analyzer is actually cell agnostic. It is basically looking at the scatter properties of the cells and as well as the fluorescence properties of the cells and placing them in a dot plot in a certain way. Now, while blasts fall in a certain region on the scatter plots, there are certain kind of benign cells also, which are not really malignant, can also fall in the same area. And at times you can have, a misconception in your mind that perhaps you're dealing with an acute leukemia. So those challenges do give you, some kind of a, if I may call it, a nightmare to identify those cells as leukemia versus a non-leukemia. For example, if you look at dengue viral illness, you will have leukopenia, cytopenia, and you'll also have the presence of these large reactive abnormal kind of or atypical kind of lymphoid cells. At times, some of these cells may lie in the region which is for blasts, and then that can give you complexities and problems. And more importantly, there are cases where you have normal platelet counts and sometimes even normal hemoglobin, and yet the analyzer has picked up certain blasts and labeled them as blasts. At that point of time, it suddenly becomes difficult for you to say whether you really are dealing with an acute leukemia or not. And in such circumstances, the ideal way is to review the peripheral blood film, which most of us do. And in fact, in majority of the new age analyzer systems, which are like the modular systems on a single track, you not only have the CBC, which is coming out from there, including the red channel, you also have information coming in from the instrument and guiding it to make a smear and stain it and also give you digital morphology in today's era, which helps you to eventually give a correct diagnosis. So overall, there are challenges, but there are mechanisms to obviate them as well. Which one needs to keep in mind when we are looking at the CBC analyzer for giving us, so-called screening part of it, not really a diagnostic part of it for the leukemias. There are parameters, for example, if you look at the lymphocyte size or lymphocyte complexity. So in classical CLL, you get what is called lymphocyte, microcytosis, and it means that the lymphocyte size becomes relatively smaller, and that's picked up by the hematology analyzer. You can also pick up blastic cells in a certain area, especially if you look at the X, Y, and Z parameters on the three-dimensional plot for these assays, and then decide whether you're dealing with an acute myeloid leukemia or not. In addition to all this, you can also have certain parameters, certain specific type of leukemias. For example, you say acute promyelocytic leukemia, that is a very characteristic scatter plot pattern which comes even on a hematology analyzer. So all of these are possible for us to look at and come to a relatively, I wouldn't say a conclusion, but at least a screening thought that this probably will be a CLL, or this probably will be a hairy cell, or this probably will be an EBML, or stuff like that. So analyzer in general will be able to give you that information. And subsequently, when you look at the peripheral blood film, that can guide you further to decide what else are you going to do in this patient, whether you're really dealing with an acute leukemia or not, and accordingly treat the patient eventually.